lovely place, but we get to meet with colleagues and make new connections and collaborations, and we really appreciate it. So I'm going to be talking today about cannabinoid pharmacokinetics and pharmacodynamics, and we're starting at 11:38, so I'm going to make sure I'm done on time. When I was at the National Institutes of Health, I had no conflicts of interest, but now that I am consulting, I obviously work with many different companies, and related to today, I've worked previously with 2 companies that are trying to develop a cannabis breathalyzer, like an alcohol breathalyzer. I'm on the World Anti-Doping Agency Prohibited Drug List Committee, which I love, all the drugs you can't use in the Olympics and sports, and also smart approaches to marijuana, and the National Safety Council on Alcohol Drugs. Okay, and I continue to do a lot of research. You saw these data yesterday from our professor from North Cyprus. It just shows you the importance of cannabis because it's used by so many more people around the world. So the opportunity to become exposed is much, much greater. And in the United States, at least, and Canada as well, young people use as their first substance not alcohol or tobacco. Their very first substance that they're starting to use is cannabis rather than the others. So it's very important, and the opportunity for cannabis dependence and addiction is greater. In North America, we have almost 20% of the population has ever used cannabis. It's gone up almost 28% in the last 10 years and is continuing. And I think we're going to see this in the future because so many young people are using even on a daily basis, and we're going to see those changes. And it's 41% of all substance abuse disorders worldwide are cannabis, which I think people don't appreciate that as well. It's been used for thousands of years. There are, if you go to Egypt, to the wonderful Grand Egyptian Museum that has recently opened, the new one, you will see mummies of young women going through childbirth, and they have cannabis to help with the pain of childbirth. The primary psychoactive substance is delta-9 tetrahydrocannabinol, which I will call THC from now on. And I think what's underappreciated is how complex the cannabis plant is. So it contains more than 500 different chemicals and compounds, over, depending upon who you follow, up to 140 known cannabinoids. And what do we know? We know about THC, we know about cannabidiol. We're starting to learn a little more about cannabigerol, cannabichromine, but there is a wealth of potential therapeutic drugs in the cannabis plant that maybe will be very helpful in the future for meeting needs, healthcare needs that we don't have now. You may be surprised to see if I can get this to work. Yeah, there's 2 different numbering systems. They're both identical, whether you're talking about the delta-9 tetrahydrocannabinol, which is the dibenzopyran numbering system, or you're talking about the monoterpene system. It's identical. It's just 2 different systems for naming the compound. Now, this is a little bit older graph, but I cannot find a newer one, but it's critically important because if you look at the pink line, which shows you how the lifetime use of cannabis has increased, that's important. You can see the increase. But the most important thing here is how much the past daily use has increased. That's the huge difference. So if you're using it every now and then, it's way less harmful than alcohol or tobacco. But if you're using on a daily basis, now you can really be changing the way that your brain works, and other important areas. If you look at the United States, we're in a mess, okay? Cannabis is still prohibited on a federal level for the entire United States, but 24 states have approved recreational use of cannabis. Okay, so we have all kinds of legal problems. We've got all kinds of problems with access by younger people. Of course, all the laws say that they can't sell it to people under 21. But you know that when you're a young person, it's easy to get from your older brother, your older friends, whatever. So then other states allow medicinal cannabis, but it's not very hard to get a cannabis medical card at all. You just show up, pay your money, and you get the medical card, and then you can have it as well. And there's just 3 states that don't allow any form now of cannabinoid access. So what's important is to talk about cannabis because it includes all these different forms that the cannabinoids are available. Marijuana really only applies to the dried flower that people smoke. So we should always be talking about cannabis rather than marijuana. But you can see now that, oh my, we have every form available. You can buy cannabis-infused beer, you can buy cookies, you can buy potato chips that have cannabis in them. And now we have so much more of the concentrates that can go up to over 95% THC. In the dried leaf, the marijuana, the highest is from Canada. Vancouver bud is very, very potent, up to 32% THC. The average in the US for marijuana is about 16%, okay? But you can imagine, and also the wax and shatter can be very, very potent forms. Dabbing is when you create this very concentrated THC kind of oil resin wax, and then they light it with a blowtorch and they try to inhale it all at once, and then they fall to the ground and they vomit and they roll and they have seizures and their eyes go back in their head, and then they get up from that mess and say, oh, that was the best I've ever had, okay? I mean, I don't see the joy in that, but some people do. About 80% of people smoke the marijuana or inhale from a vaporizer or dab. E-cigarettes now, very popular for putting cannabis oils in. The vaping has certainly increased. With vaping, the temperature is lower, so you supposedly do not volatilize some of the more harmful carcinogens that are present in cannabis smoke, and get the THC, the cannabinoids, without many of the problematic compounds. But what's so interesting, there are more carcinogens in cannabis smoke than tobacco smoke. But we don't have a lot of throat cancer, mouth cancer, lung cancer from cannabis. And in fact, there are some components in cannabis that have been shown to stop the growth of cancers. And there's a lot of work going on to try to see if they can develop medications that might be effective. So as you would expect with something with a lot of carcinogenic compounds, that does not happen with cannabis. And then edibles are becoming more and more popular. A lot of people enjoy an edible better than a glass of alcohol, even the no-name alcohol that we had last night. And it's really got less morbidity and mortality than alcohol. So the potency of hemp in the United States is, we have our wonderful 2018 Farm Bill, and hemp says if you have a plant from cannabis, and we only have one species now, There used to be multiple species. There's now just Cannabis sativa is the same as Cannabis indica. They're all so interbred. If it's less than 0.3% THC, it's legal hemp. In Europe, they use less than 0.2% THC. But I can tell you, if you use an oil that has less than 0.3% THC on a daily basis, you can test positive in a urine cannabinoid test, which has caused a lot of problems. For instance, in sports testing, we made cannabidiol not prohibited. I pushed that forward about 10 years ago. The problem is that sports people cannot go buy cannabidiol and use it maybe as an anti-inflammatory because of the trace levels of THC. And they take a big risk that perhaps they could come up positive on a test. The big problem now is that we have, the way it started was cannabidiol became very popular. The farmers grew way too much cannabidiol, produced it. They didn't sell it. So some very clever people found out if you treat it with acid and heat, you can turn it into delta-8 THC. Older data and one newer research paper shows that delta-8 THC is approximately 50 to 70% the potency of delta-9. So all you have to do is take a little more of it and you get the same kind of response. And yet it's legal in the United States because it's delta-8. The Drug Enforcement Agency says it's not legal, but you can buy it at your local convenience store or whatever. So real problem. And now we have, besides delta-8, we have delta-10, THCO, THCP, and you're going to hear a lot more about NPS, novel psychoactive substances, from Dr. Ellison later today. The other thing that happened is when the delta-8 came on the market, and this is very important for laboratories, the delta-8 interfered with the measurement of delta-9 THC, and its metabolite, delta-8 carboxy THC, interfered with the measurement of delta-9 carboxy THC. Generally, they did not produce false positive results, although it was possible. They produced false negative results. So that was very important with a lot of false negative tests being turned out by laboratories. All of the labs are fully aware of this now and have had to do new method development and validation. Okay, so I'm going to throw a lot of pharmacology at you. And the most important thing is for you to understand the importance of the endogenous cannabinoid system in our bodies and our brains. So all of us have an endogenous cannabinoid system that is critical for survival functions. The endogenous cannabinoid system, even though we didn't find out about it until the late 1980s, early 1990s, it has been highly conserved throughout evolution. In fact, it's present in the Hydra one-celled organism. And it is so critically important in both physiological, cognitive, and behavioral effects, as well as psychomotor effects. And it's involved in things like hunger. If you don't eat, you die. If body temperature, if you can't keep your body temperature constant, you will die. If you don't reproduce, the species will die. So it is absolutely essential. And what the endogenous cannabinoid system attempts to do is maintain homeostasis, okay? When anything gets out of whack, it tries to pull it back to homeostasis. So very critically important role. There are receptors which is what we found after we found the endogenous ligand, the actual neurotransmitter that binds to the receptor, and of course, all the other things that are important with synthetic mechanisms, degradation mechanisms, etc. So when someone uses cannabis, they basically hijack the normal function of the endogenous cannabinoid system. And this is critically important because if it can't maintain homeostasis, when someone's using cannabis, it can get out of whack. So I am a huge believer that there's going to be tremendous therapeutic potential with the endocannabinoid system. Right now, we're learning about how critically involved it is with pathology. When there's a problem with the endogenous cannabinoid system, it produces all kinds of different diseases. The problem is that no pharmaceutical company wants to invest the millions and millions of dollars to develop a cannabinoid product if they can't make money. And you can't make money on something like cannabis that is a compound that's produced all over the world by different things. So the problem is that we have not run the clinical studies that are necessary to prove the efficacy and safety. And that's a huge problem for us. So we have G protein coupled receptors. They are the most abundant receptors in density in our brain. And guess what? The CB1 cannabinoid receptor is the G protein coupled receptor with the highest density in the brain. So this isn't some little system that doesn't matter much. This is one of the most important neurotransmitter systems in the brain. We find it in all different animals, birds, and as I said, down to the hydra. And when I started learning, I teach an entire course in cannabinoid pharmacology. I cannot use a textbook. There is no textbook that covers, because it's being investigated. Every year I have to change the course because there's 1,000 new papers on what we're learning about the system. So when I started out in cannabinoids, we knew about the CB1 cannabinoid receptor. We knew about the CB2 receptor. The CB2 receptor, I'm not going to talk a lot about today. It's primarily in the immune system, very important for resistance to disease, very important that we'll learn about with disease. And there was a big debate on whether there were CB2 receptors in the brain. I think that has been resolved now. For maybe 10 years. It turns out there's a very low number of CB2 receptors in the brain. But when there's any brain insult, so you have hypoxia or you have a disease of the brain, then the CB2 receptor increases tremendously, trying to help solve the problem, the insult on the brain. So that's CB2. The CB1 is not only in the brain, it is throughout the body, especially in the cardiovascular system and other areas as well. But now we've learned there are many of the TRP ion channels that are cannabinoid receptors. There's something like, you can see here all the different ones that I've shown at the bottom of the slide, but we have nuclear PPAR receptors for cannabinoids that transmit messages, as we were talking about yesterday, into the brain for development of different proteins. And now there's hemopressin receptors. Every year we learn about more cannabinoid receptors. Now I'm going to take you through this because I think it's important, but it's a little bit complicated. So first of all, let's talk about the ligands. So we have anandamide. This was the first cannabinoid neurotransmitter discovered. Anandamide was named by Rafi Mechoulam, who is the investigator who first discovered that THC was the primary psychoactive compound. He was a very dear friend of mine. He passed away a couple years ago, and he's called the father of cannabinoids. So anandamide means bliss, okay, so that's why he named it that. But look at it, it doesn't look like other neurotransmitters where we expect peptides, okay? It's actually an unsaturated fatty acid with this amide alcohol group on the end. And then we have 2-arachidonyl glycerol, which has a similar structure, but these are just the 2 that we know the most about. There are literally dozens of these compounds that can transmit messages through the cannabinoid system. Now, if we look over here, here's the presynaptic neuron, here's the postsynaptic neuron, and an impulse comes down to send a message, and of course we know that that's an electrical message that's coming down, and it comes to this membrane and it depolarizes it so that the right here, the neurotransmitters that are stored in vesicles in the presynaptic neuron, and these are not cannabinoids. They are glutamate, an excitatory, stimulatory neurotransmitter, or GABA, or one of the many other neurotransmitters that are stored in vesicles. So the membrane is depolarized, these move to the membrane surface, release the neurotransmitters into the synaptic cleft, and so we change from the electrical stimulus message to a chemical stimulus message. They come down and they bind to the postsynaptic neuron, and these receptors are the receptors for the neurotransmitters, the glutamate receptor, the AMPA receptor, GABA receptor. Then there's a second messenger system that happens when these are stimulated, and it goes to the membranes, and right here, stored in the membranes, are the endocannabinoids. And the endocannabinoids are actually very lipophilic. Cannabinoids are very lipophilic, meaning fat-loving, don't like water at all. And these endocannabinoids that were not stored in vesicles, took us a long time to find them, they are released and they do a retrograde migration back to the presynaptic neuron, and here are the cannabinoid receptors. Again, another reason it took us so long to figure out what was going on. Nobody expected them to be in the postsynaptic membrane. Nobody expected a retrograde migration, and nobody expected the cannabinoid receptors to be on the presynaptic neuron. Now, this is why they're so important, because once these are stimulated, they turn off the release of the other neurotransmitters. And that's essential, because you have to turn off the release and allow this membrane to get repolarized and to synthesize new neurotransmitters so you're ready for the next message that's coming. So it shows you that the endogenous cannabinoid system sits on top of the other neurotransmitter systems and helps control the way we send messages. So I hope this has convinced you how important the endogenous cannabinoid system is. Now, where are the receptors in the brain? So if you talk about evolution, we started obviously with this small brain in earlier development. And then as we developed the human race, we grew and grew and grew the size of our brain. And we created this entire cortex, okay? So if you look right here, the amygdala, this is the center of emotions. And this is why people take cannabis, because of the relaxation and the euphoria they feel when they take it. But it's also the center for anxiety and fear, okay, and other emotions. Many, many cannabinoid receptors in the amygdala. If you look at the hippocampus, the center of memory and learning, many CB1 receptors, and why I personally do not approve of cannabis legalization. And it's only because of what it does to brain development. So when you have a pregnant woman who's using cannabis, it's going to tremendously affect the fetal development of the brain. The endogenous cannabinoid system is critical for how the neurons connect when the brain is developing. And if they're exposed to THC, those connections may be made differently as the brain develops. Breastfeeding, we're going to talk a little bit later about young children being exposed to secondhand smoke from parents, and then of course adolescents who start using themselves. And I say adolescents, but we know now that many children are starting at age 9 and 10 with cannabis. Use of cannabis before the age of 17 tremendously affects brain development. I could talk about cannabis for a week, okay? So I got to be careful. All right, so we do not have CB1 cannabinoid receptors, very many at all, in the brainstem, which is why I always used to say, cannabis is not going to stop your heart, it's not going to stop you from breathing, it's not going to kill you, okay? Because we don't have those receptors in the brainstem like we do for opioids, and why we have such an amazing opioid epidemic of deaths in North America, especially. Only the vomiting center has CB1 cannabinoid receptors. If we look at the basal ganglia and the cerebellum, very important parts of the brain for motor control, motor planning, initiation, and this is why cannabis really affects driving and operation of complex equipment, okay? Is because its effects on these two centers. And then we have also the hypothalamus, where you know cannabinoid munchies, right? People get hungry when they eat. Very important for hormones and sexual behavior. The CB1 receptors are located on the sperm head and important for the sperm finding the egg and fertilizing the egg. And then the fertilized egg, the cannabinoid receptors are critical for implantation in the uterus, okay? But here is this huge cortex we have developed. And that is critically important for executive function. And executive function involves everything. Your sensory, taking in all the information from your environment. Next step, evaluating whether it's salient or important or not. And because we can't handle all the information that comes in, so what are we going to pay attention to? Then you compare it to your memory. And what do I know about this? How am I going to respond to this? What does this mean to me? And then you have to decide the function, what are you going to do? How do you respond? And then you have to do it. All of those are steps in executive function. And cannabis affects all of those steps. So it slows down your ability to respond to changes in your environment. And that can be very critical depending upon the circumstance. All right, so we've talked about these, but these are just some of the important functions of the endogenous cannabinoid system. Wait till she gets a picture. Okay. All right. So with subjective effects, we know the high, but we also know the paranoia, and boy, is that appreciated. I have personally experienced cannabinoid paranoia in our participants, and it's quite interesting. We can get psychosis. There's a lot going on now with cannabis and psychosis because of the high potency. With the higher potency cannabis, we are having many more problems with psychosis. I'm not going to say more about schizophrenia, maybe later. When we talk about the window of drug impairment, it includes the onset, the peak, and the duration of the effect. And when we're going to hear a lot today about drug testing, and there we talk about the window of drug detection. So all the different biological matrices, urine, blood, oral fluid, hair, sweat, whatever, they all have different windows of drug detection, and they may or may not match well with the window of drug impairment. We're going to talk about that later. Okay? And it's really important when we talk about behavior, is realizing that it's the combination of all the physiological, motor, psychological, all of the effects that are going on are shown as an individual's behavior. So it's all of them together. Now, cannabis increases dopamine in the brain. All drugs of abuse, somehow, different mechanisms, increase dopamine in the brain. But we have natural rewards like food. Oops. There we go. Like food. So you eat, you get an increase in dopamine. It's a rewarding feeling. Sex, another natural reward. And then all drugs of abuse, like cannabis, will also increase it in the nucleus accumbens of the brain. And Alan Leshner, long time ago, was the director of NIDA. And I really liked the way he described addiction as, you have this whole spectrum of effects that occur over time. But at some point, when someone uses a particular drug, heroin, cocaine, whatever, long enough and frequent enough and in high enough amounts, it actually changes the brain. It actually changes the way you respond to the drug and to other natural reinforcers. And that he described as addiction. When that change has been made, where the compulsive use occurs, and the individual is really no longer in control anymore. Okay, so we're going to be talking, this was my first paper way back when, and whoops, okay, let's see that. Okay, so when I ran my very first study as a graduate student, everybody before had used a paced smoking procedure. So they had a computer and it said inhale for however many seconds, hold in your lungs, and exhale, okay? And then it controlled the number of puffs, the time between puffs, everything. So I did my first study as a paced procedure. And all of the studies started after the person stopped smoking. So they smoked it, and then as soon as they finished the cigarette or joint, they started taking physiological measurements, psychological. I wanted to know what happens while they're actually smoking. So we had a blood withdrawal pump, a continuous blood withdrawal pump. I didn't have any automation. I sat right next to them while they smoked. I breathed it in, everything. And I moved the little tube from blood tube to blood tube to blood tube. We took 5 milliliters of blood a minute. I say a lot. For the first 20 minutes, then 1 mil a minute, and then 0.2 mils a minute. So we could characterize what is going on while they're smoking. And it shocked me because you can see all the different physiological effects that we expect. The increased heart rate, tachycardia, obviously. But what I noticed was that we used 2 different potencies of THC, which I don't want anyone here, all the former students know this, Delic knows it. Don't say to me, these are low potency cannabis, okay? Because what we discovered is that people titrate their dose. You give them a low potency cannabis cigarette, they are going to smoke it differently to get as much of the THC out as they can, okay? longer breaths, longer hold times, and guess what? The data that we published are some of the highest THC concentrations in blood that have been published, because that's how people titrate, okay? So notice that even though they're double the potency, the heart rate is pretty similar between the two doses. That's because they're actually getting in the same amount of THC. And if we go to the subjective effects, look at the field drug. They sit right on top of each other, right? They feel the effects the same because they're getting approximately the same amount of THC. So here's all these, you can read these, all the different effects that we expect. We already talked about executive function. Divided attention is one of the most common things that happens with cannabis. The inability to attend to multiple things at the same time. And this is placebo effect. So we have a double-blind, randomized study, and they're really hoping it's going to be active THC, but they find out very quickly that it's not. Okay, so that's just the expectancy effect. Look at this. When they start, even the first puff on a cannabis cigarette, they feel the effects. Not only did we collect the blood very rapidly, starting at 1 minute, we collected all the subjective effects, the physiological effects, and by 1 minute, they know that it's active drug. They're feeling the psychological effects in the brain, and their heart is starting to beat. So why do they titrate? Why do they stop? Why don't they just go as high as they can go? So there's a couple of things. From a physiological perspective, they are not comfortable with their heart beating out of their system. I mean, that's frightening when that heart rate goes up so much and they feel that. Different people feel it differently. And then the psychological effects, they start to feel that right away. But a lot of people don't want to be out of control. They want to feel the relaxation, but they don't want to feel like they can't control their what they do. Okay, so that's what convinced me, don't do a paced smoking procedure. Do it ad lib. Let the person take the amount of drug they want. And almost all of our studies are done that way if you read our papers. So I'm not going to talk a lot about medical cannabis, but what do you think? Is this medical cannabis, Marinol or Dronabinol, that's approved by FDA and EMA in Europe? Cesamet, the Sativex, which is the first, the group, GW Pharma in the UK, wanted it to be a full spectrum cannabis product, but the FDA would not approve that, so it's 99% pure. It's 1-to-1 CBD, CBD THC, that is a full product. It's the Epidiolex, which is the first medication that is helpful for reducing seizures in children with Dravet syndrome and other bad neurological diseases. So is that medical cannabis or is this medical cannabis, right? That's what is approved in the US and many other countries, is this can be used medically too. The problem is this, you know what you're getting each and every time. It's a pharmaceutical product of known components and concentrations. This changes all the time. How do you control that 500 compounds in cannabis is uniform and is the same every time you take it? The terpenes change. The relationship between the different cannabinoids change. So this is really holding us back also. What should be the medical product and how can we possibly standardize it? So if you find a dose that works for something, it's the same every time you get it. This is what really started medical cannabis in the United States. This is the young girl, Charlotte, who had over 200 seizures a day with Dravet syndrome. And if you're interested, I would really tell you this is an excellent report. It came out in 2017, so it's a little bit dated, but it lays out, it's done by the National Academies of Science in the United States, and it lays out most of the issues with the cannabinoids. Cannabidiol, I'm just going to talk a little bit about, but it's so important. It does not bind well to CB1 or CB2 receptors. We know that it's an allosteric modulator, meaning it doesn't bind at the main binding site, but it binds somewhere else on the CB1 receptor, changes its conformation, its structure, so that it binds differently in the main binding pocket. But it definitely increases serotonergic and glutamatergic transmission, and we don't yet fully know its mechanism of action. We're still learning about it. We do know that it activates the TRPV1 ion channel. That may be how it reduces anxiety. Okay. Now, it's metabolized by similar enzymes that metabolize THC. And one of the big problems about cannabidiol is that everybody and their dog are taking cannabidiol. It's used tremendously in veterinary medicine now. And people are taking it. They don't think of it as a drug. They don't tell their doctor. And it can have a lot of drug-drug interactions. So people on blood, hypertensive medication, it can change the effectiveness of different medications. So it's really important that you notify people, and it binds to so many different receptors. So these are just some of the potential uses of CBD, but what did I say before? We don't have clinical trials other than reduction in seizures. That's the only use of CBD where we have good clinical trials documenting efficacy and safety. So I wrote this paper, I don't remember, 2019, because it's not that I'm against cannabidiol, it's that people are not stopping and thinking about the other effects of it. So if you're interested, we lay out the good and the bad things about CBD and all the potential for interactions. Okay, so let's get on to some pharmacokinetics. So inhalation, you know that when you do a drug IV, it goes right into the bloodstream, right? And then it circulates and it gets to the brain. Inhalation is almost as fast as an IV injection. Okay? It goes right in to your lungs, goes to the left side of the heart, and then straight into the blood up to the brain. So the THC that you inhale reaches the brain really quickly. It's in terms of milliseconds from when you start to inhale. So it's a very rapid way of delivering drug to the brain. And as you know in your work in the commission, that almost all drugs can be inhaled. I mean, now we have PCP, they're doing heroin through inhalation. Methamphetamine, all the typical drugs of abuse, not psilocybin, but can be taken in and very rapidly go to the brain. The drug abuse liability of a drug is completely related to how fast it can be delivered to the brain. So the more rapidly you increase and get the THC concentration in the brain, the greater the abuse liability. Okay, so smoking dynamics are very, very important. How they smoke it, as we talked about, and about titration, which I've showed you. What happens when they smoke a cannabis cigarette? About 10 to 20% is left in the butt that they never get into their body. almost a third to a half is destroyed by the high temperature of the burning ember. And depending on how they smoke it, somewhere between 16 and 69% could get in. The 69% came from smoking machines where they actually took it in 100% of the time and up to 69%. So if people ask me, how much do you get into the body? I will say it depends how you smoke it. But on average, maybe about 25% of the THC gets into the body. Edibles, of course, can you titrate when you take edibles? No, you take the whole thing in at once, okay? No titration. Now the bioavailability is much less because it's going into the stomach, it's getting destroyed by the low pH of the stomach, then it goes right to the liver where it gets metabolized. So the bioavailability of edibles is somewhere 6 to 10%, and they've made it more bioavailable. The producers are now coming up with sophisticated ways of increased number of triglycerides in the product that make the bioavailability higher. Vaporization, I think we talked about that already, a lower temperature. And this was from my very first paper, and I'm really proud of it because it's the only one that will show you the entire time course during absorption. So to look at this, we have THC on the y-axis in nanograms per mil. We have minutes on the x-axis, and each one of these arrows is a single puff on a cannabis cigarette, okay? And you can see how rapidly the THC concentration increases, shoots straight up. And then what happens? Up here, they're really feeling the heart rate, they're really feeling the psychological effects, and they change the way they're smoking. Fewer puffs, less inhalation, less holding in the lungs. And look what happens. The concentration levels off, and in every single person, the peak THC concentration occurs before the last puff on the cannabis cigarette. So the peak THC concentration occurs before the end of smoking. And then look at the decrease, rapid decrease. THC is so fat-loving, it is not soluble in water. It has to be carried around by proteins in the blood. And it's very lipophilic, so as it's going through the blood, it's just pulled off into the tissues, pulled right off. So when you see this huge decrease in the blood, that does not match the concentrations in the brain. The brain is a very lipophilic organ. It is very fatty because of the myelin around all of the neurons. So the THC gets into the brain and stays in the brain. We even have a paper from French colleagues in motor vehicle fatalities showing higher concentration in the brain when it's not even detectable in the blood anymore. So you can't be thinking, this is the pharmacokinetic profile. You can't be thinking that's what's happening in the brain or in the rest of the body. Okay, now that was mean or median data. This is individual data. And look here at this blue line, subject E. This guy had the lowest peak concentration because guess what? He had the strongest cardiovascular response. His heart rate was through the ceiling. So he's not comfortable at higher concentrations, right? Because he's feeling here. These are my stars right here. These guys are daily cannabis smokers. Look at the concentrations they reach. This is the same potency cannabis cigarette. This is why people should be allowed to smoke as they want, because these guys are loving being up here at 250, and this guy's uncomfortable even at 90 nanograms. Okay. All right, hysteresis, another complex topic. I ought to make Marisol explain this to you. So hysteresis is important for you to understand. This is work by Dave Schwope. And what I want you to see is this is what you see in most textbooks. They don't measure during absorption. So what you see is here they are. This is a visual analog scale for how strong do you feel, or how good is this drug effect right now, and you ask it repeatedly. Well, the first measurement is up here at 15 minutes after they finish smoking, and they're high as a kite, okay? They really feel the effects. Over time, look how the THC concentration is dropping really quickly. That's in the blood. But the effects stay high for a much longer period of time. And then they slowly come down, okay? Now, this is work from my dissertation, and we have here absorption. So over here, we have the subjective effect of how strongly do you feel the drug. Over here, we have objective heart rate, okay? Look during absorption. This is all during smoking. It's almost a straight line up. And then we have distribution, and the THC is dropping so quickly, but the heart rate stays up, and the feel drug stays up, okay? And then finally, after the initial distribution, about 45 minutes, then the effects change again. So, how do you interpret this if you're trying to interpret a drug concentration? If you take 50 nanograms per mil, are you here with very little effect, or at the same concentration, are you up here with a very high effect? Makes it difficult to interpret cannabinoid concentrations, right? So this is called a counterclockwise hysteresis. This is a concentration effect curve. And when you plot the concentration against the effect, and you see this, it's very typical of drugs that have a very large volume of distribution. Okay? You can have clockwise hysteresis, going completely the other way. So in this graph, each one of these points is a blood collection, okay? So they're increasing in time. With nicotine, it goes the other way. It's a clockwise hysteresis. Okay, so now you've got that one down. All right, so this is work from Dave Schwope, one of their colleagues, and it's just important to make sure that I tell you, the concentration of THC in blood, whole blood, is about half the concentration of what it is in plasma that's taken at exactly the same time. You have to be very careful when you read papers, whether they're talking about blood or plasma or serum, like in Germany, because of that difference. Why? THC doesn't get into red blood cells well. It just doesn't get in. And red blood cells are about half, 40, 50% hematocrit. So that's why it's about twice the concentration in plasma or serum than it is in whole blood. All right, we've talked about distribution. This is just showing you, here's the THC, whoosh, rubs up and then down. Here's the 11-hydroxy-THC, the first metabolite of THC that is active and just as potent as THC. So whenever anybody's measuring the drugs, they need to measure THC and 11-hydroxy, or you're missing some of the potent drugs. has a very large volume of distribution, and this is important. The slow release of sequestered drug from the tissues is the rate-limiting step in its elimination. So if you're an occasional user, you smoke less than every day. Our definition in our papers is an occasional user is someone who smokes less than every day. And it turns out that if you smoke every day, at least one joint, blunt, whatever, every day, you're taking in more drug than you're able to excrete out in that day. And so you start storing the THC in the body and you start building up, and it's the active drug you're storing, the THC. So it remains active in the body. And I don't know if I'm going to have time to get there, but we'll see. All right, here's the metabolism. We go THC, we get oxidation to 11-hydroxy-THC, we get further oxidation to carboxy-THC that is inactive. It is not active in the body. And then all three of these have glucuronic acid attached to it by the body because this is an exogenous substance that's not in the body. We try to make it more polar so it's easier to excrete out of the body. So all three of these compounds also can get glucuronidase to help with excretion. Okay, so this was our last study. One of their colleagues, Matt Newmeyer, and you can see other people in the lab here. So here is the THC concentration. Here is time, logarithmic scale, not a linear scale. And you can see the hashed gray is during smoking. And you can see we have 3 routes of administration. It was my last study. We wanted to do everything. We did oral THC, smoked THC, vaporized THC in every subject. So within subject design, the same dose, a hefty dose, 50 milligrams of THC by the 3 routes. And we did it in 2 populations, the occasional user and the chronic frequent user. So I'm going to point out the differences. So why do we have logarithmic scale? Because the concentrations get so high that you have to do a logarithmic scale to be able to see things. And the 3 routes, the black is smoked, the blue is vaporized, and the purple is oral, okay? So notice the concentrations in the occasional users, they come in negative, okay? They don't have THC when they come in. Shoots up, you can see the smoked and the vaporized, they sit right on top of each other, very similar, and then they slowly decrease over time. The oral, they come in, the peak is much later, 2 to 4 hours compared to minutes, about 8 or 9 or 10 minutes when they inhale it. It increases and then slowly decreases. What's important is knowing the pharmacokinetics because the effects are going to be different. The peak is going to occur much later and the duration of effects is much longer than when they inhale. So this is the occasional user. Here's our chronic frequent user, and they're different. Okay, they come in with THC in their blood. We have a closed research unit where they stay on the residence the entire time. I've run studies as long as 90 days previously, so they have no access to drugs. Okay? So they peak, they come in, they're positive. We keep them on the unit for 19 hours approximately before we dose them because we want to get rid of what they have taken themselves before they come in. They don't get down to 0 because these are chronic frequent users. They have so much stored in their body that they're still excreting out after 19 hours. They're still excreting out drug, and then they will peak, they will go higher than the occasional users, and they'll decrease, okay? Here's the 11-hydroxy, the active metabolite. The concentrations are much, much lower after smoking and vaporization. We actually get higher concentrations with oral administration because with oral it goes into the liver where it's metabolized to 11-hydroxy. So with oral administration, you expect much higher 11-hydroxy concentrations peak than after the inhale. Again, you see they may come in with some in the chronic frequent users, and then they have a similar pattern. And look at the carboxy. This is the free carboxy, but you can see they even the occasional users can come in with low concentrations of the carboxy metabolite. It peaks much later, and you can see really high concentrations, higher concentrations after the oral. Look at the chronic frequent users. We've given them 50 milligrams. You don't even see a bump, okay? They have so much drug on. So I like to think of my career in two parts, and we'll just go a little bit more and then we'll stop. Acute, we studied acute cannabis exposure. And then I have now tried to figure out how to study chronic frequent users. That's the problematic population, especially, okay? So how do you do that? For safety and ethical and medical and even financial reasons, you cannot give people as much drug for as long as they take it themselves, right? You just can't. So we can't do that in a controlled situation. So we finally figured out, okay, bring in the most chronic frequent users. We will bring them into the unit. We will measure everything, including brain imaging, the concentrations of, the density of receptors in the brain, and we'll study them that way for 30 days. Okay, so before we did this work, every toxicologist in the world would have said that if you find THC in the blood, it means recent use. Now, some people say recent use is 3 hours. Some people say recent use is 6 hours. Some people might even say as long as 12 hours, but everybody would have said recent use. And so you'll see what happened. These chronic frequent users used on average 10 joints or blunts every day for the last 10 years. These are really chronic frequent users. And 26 days after being on a closed research unit, 10 of 11 of these individuals, we could still measure THC in their blood. Low concentrations, but we could still measure. Okay, this is Dr. Karshner's work, whose birthday was yesterday, and we were only allowed, we have ethical committees. The ethical committee, I wanted to take blood for 30 days. They said, why should we allow you to take it for 30 days? You only show that it's present for like 12 hours or so. And so we could only do it for 7 days. So this is our first study. And I want to show you, we had 28 of these daily users and a very low detection limit, very low, but on half of them were negative within 24 hours. Okay, kind of what we thought, but 15 were still positive. Next day, 14, 12, 9, everything looks like you expect it should with blood. Uh-oh, day 5, more people are positive. How is that possible? It should always go down in blood. And by 1 week later, we still had 6 people with measurable THC in blood. This is what it looks like in 5 people that were positive every day. All of the 15, only 5 were positive every day. The others would be negative, positive the next day, negative, positive the next day. Why? Because the THC is being released from their fat tissue enough to produce a positive test. This is really important for drug treatment programs because many people sign contracts. I will not use drugs while I'm in the treatment program. They take urine samples, negative, 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 suddenly positive. You used the drug. And they say, no, I didn't. So this was huge for treatment programs. We showed this same pattern in sweat, with patches, with urine, with coming positive and negative, and in blood. So look at these 5. These are the only 5 that were positive all day. They started at about 2 nanograms per mil, dropped down to about 1 nanogram per mil, just didn't change. And now you'll see they were all women and not very large women. So you know that the first thing we thought was, well, okay, if you have a larger body mass index, more body fat, you're storing more THC. Not true. Not true in women, not true in men. Had nothing to do with their body mass index. But for women, there is something with hormonal or whatever where we have much longer detection times in women than men. We showed it in urine and in many other matrices. Okay, so then after we did this, we were able to say to our ethical committee, hey guys, we need to be able to measure this in blood for a longer period of time. We got the opportunity to do this study only because we partnered with a pharmaceutical company. Can you imagine keeping all of these individuals on a closed research unit for 30 days? It was a multi-million-dollar study to run, and it was because we were working with a pharmaceutical company on the very first CB1 cannabinoid receptor antagonist, Ramonabon, which was approved in Germany initially as a drug treatment tool. This is what we found. It was amazing. Okay, so here's the THC. This is on admission, 90% were positive in blood for THC. And look how slowly it decreased. You've got to look here at the number of participants. And you can see it decreasing by day because our participants are volunteers. They can leave whenever they want. And of course, they're going through cannabis withdrawal. And many are very unhappy. They're irritable. They're not sleeping well. They're really feeling the effects, so they choose to go home. So that's where you see that. And we even were able to measure in 2 people on day 30 THC in the blood. Okay, so now I'm going to just show you a couple more things. Everybody says, just give us a number. What is the number that means cannabis impairment in blood? There is no number. I have told every government that I've gone to, every state, there is no number. So why? Look here. So this is our chronic frequent users. Where's my pointer? There we go. Pointer doesn't work so well, guys. All right, this is the chronic frequent users right here. If you use a 1 microgram per liter, which is the same as 1 nanogram per mil, if you use a 1, they're going to all be positive for 20 hours or more, and then it'll start to decrease. If you look at the light blue, which are our occasional users, when they smoke, they're all going to be positive at 1 for a short period of time, and it's going to decrease, and by about 7 hours, the occasional users are going to be negative. That might be a good window of detection for occasional users because impairment may last somewhere up to that 7 hours. But what if you use a 5 nanogram per mil? Now you go to the black triangles, First of all, now only about 70% are going to be positive. Come on, pointer. There it is. About 70% positive at 5 nanograms per mil. They stay overnight. We dose them, and they're going to shoot up here. But look how quickly they're going to drop. And oh my, you get down at about 16% of chronic frequent users are going to be positive at 5 nanograms per mil for days. If you look at the occasional users, it's much worse. You come over here, you let them smoke for a very short period of time. They're all going to be positive. This first sample's at 30 minutes, so concentrations have dropped. By 2 hours, they're all negative. So if you choose the 5 to maybe be fairer for the chronic frequent users, you're going to have so many people driving impaired that are occasional. So there is no number which represents impairment. And I'm just going to show you 2 more things. This is the brain imaging, and it's amazing data. This is one of the first, I would say one of the best, indicators of a change in your brain with chronic cannabis smoking. So if you look at the black bars, these are the controls, okay? And we actually were able to measure the density of CB1 cannabinoid receptors in different brain areas: anterior cingulate cortex, amygdala, caudate, hippocampus, insula. So we could actually narrow down to the specific brain area. Every place you see stars, there was a significant reduction in the density of CB1 receptors in that particular brain area. So smoking cannabis every day, stimulating those receptors, the way the body tries to adapt is by removing the receptors so you can't stimulate it anymore. If you remove those receptors, can they function as they should? The endogenous cannabinoid system, no. So your body, in adapting to the constant stimulation, will remove these receptors so you can't stimulate them. All right, and this is after 30 days. I only have 14 people left, but I was shocked. After 30 days of continuous sustained abstinence, the body, brain can readapt and increase the density of the receptors back to normal, okay? So there's hope. If they stop using, that the brain can adapt. And I just want to say that that may not be true for every effect. So Nadia Solowish, who's an excellent cannabis researcher from Australia, 10 years after chronic users stopped using, they still showed slower nerve conduction speed, even after not using. So there can be some effects that might be very long lasting. And the last thing I promise, so we know there's cognitive deficits with cannabis that can last 30 days, okay? So you start to see a pattern. After 30 days of abstinence, the receptor density went back up. After 30 days of abstinence, cognitive function seems to return in many studies. And what about psychomotor performance? So in these same individuals that we did the other work, we looked at psychomotor skills. This is tracking error, and we were really surprised. This is the control tracking. Here's the chronic frequent users, 24 hours at least after last use, and they are significantly impaired to controls. That didn't surprise us. But look, 1 week, 2 weeks, 3 weeks after last use, they still had significant tracking performance, psychomotor performance. And if you look at divided attention control losses, again, you see improvement, but still significantly impaired. So in that population of chronic frequent cannabis users, in some they've documented cognitive impairment for 30 days. We documented psychomotor performance for 3 weeks. And I'm going to stop there. And thank you so much. It's lovely to be here, and we look forward to the rest of the meeting. Thank you. Any questions? Come on, I asked a lot of questions.
Yeah. I'm often asked by cannabis users, chronic cannabis users, about cognitive functioning and cannabis and attention deficit hyperactivity disorders. And I have some patients myself with the diagnosis, and they always say it helps, improves thinking. What's your opinion? There's very little evidence on the medicinal benefit. Clinical trials, what is your
Yeah, so she asks about cognitive impairment, cannabis use, and ADHD. So first of all, I want to say something about schizophrenia. So I would say there's still some debate in the world about whether cannabis can produce schizophrenia. I am on the opinion it does not produce schizophrenia, but it causes the first psychotic break to occur earlier. So vulnerable individuals who have the genetic predisposition, if they smoke cannabis, you see that first psychotic break much earlier. People who have schizophrenia, and there were many in our clinical studies, people who have schizophrenia in the United States, 95% report smoking cannabis. Huge percentage. They say it helps them with their cognitive deficits of schizophrenia. It helps them focus more. We know that cannabis can cause anxiety, depression in young people. I mean, I think that's pretty well shown. It can increase aggression, violence towards oneself and others. I don't know, because one of the things that I found out, if I gave the subjects an easy task, arithmetic, to do during cannabis, looking for cognitive functioning, they could do just as well when they're sober or when they're high. And I didn't understand it until somebody did it in brain imaging with functional magnetic resonance imaging. And what they showed is if you give them an easy task and you look at the brain, just a small part of the brain is lit up active. But if they're high, they can get the same score, but they're using the whole brain. They have to recruit much more of the brain. And a big problem is divided attention, which explained to me why they have problem with divided attention. If the whole brain is already working, how can you have the reserve to handle all this multitasking? So I don't know, but there's enough talk in patients, both schizophrenic and now you're saying those with ADHD. I don't know. I do know that we've had a huge debate at WADA, the World Anti-Doping Agency, about whether THC should be prohibited or not. So half the world want to put you in jail, and if you use it, and half the world's like, well, alcohol and tobacco are legal. In researching, I've published 2 papers on cannabis in sport, and the one a group of us published a year and a half ago. You wouldn't believe how many athletes said they used cannabis and they perform better. And one of the things that they told us why. One of them was for long distance runners. It helps them focus more on just running and not focusing on the pain or the distraction of the crowd, just to keep running. So I don't know. I don't have an answer, and I don't think we have research to answer that question.